Are you ready to elevate your expertise in pediatric critical care? Welcome to the Pediatric Critical Care Fellowship, a premier one-year online program designed to equip you with advanced knowledge and skills in managing critically ill children. Our aim is to provide you with high-quality educational materials and up-to-date pediatric critical care information delivered by a panel of highly qualified international expertise. Our professional panel ensures that the curriculum is current, evidence-based, and well-structured. This comprehensive fellowship is structured as 3 modules, 16 weeks each, with a total of 96 credit hours of in-depth training, delivered by a world-class faculty of international experts. Our curriculum ensures that you stay at the cutting edge of pediatric critical care. Your journey with us includes weekly lectures, MCQs, interactive case-based discussions, journal clubs, and virtual simulations, featuring the latest evidence-based pediatric critical care knowledge, plus a dedicated mentorship program to guide your learning every step of the way. From mastering mechanical ventilation and sepsis management to specialized training in mechanical circulatory support and neurological critical care, you will develop essential skills to manage critically ill children in any healthcare setting. Upon completion of the fellowship, you will enhance your credentials, advance your career, and improve your patient's outcome. With access to a cutting-edge smart learning platform, virtual case scenarios, and real-world applications, this fellowship bridges the gap between knowledge and clinical practice. Join a growing community of critical care professionals who have transformed their careers with this fellowship. Don't miss this opportunity.
Hello, everyone, and welcome to our Pediatric Critical Care Fellowship webinar. We have a very special webinar today and also very special guest speakers. This major topic today is we are trying to unmask, unveil, expose the hyperinflammatory status in our PICU. So we'll focus on HLH and MISC in pediatric ICU. We have great speakers today. Dr. Ali is going to give us a case-based discussion. Dr. Balav Batari is going to talk about HLH, and Dr. Udira is going to try to unexpose the MISC in PICU. And the great moderator, Dr. Michael Canary and Dr. Turki Alatibi are going to handle the questions and try to help answering those. So here is our humble agenda today. After this brief intro, Dr. Ali is going to give 10-minute case-based discussion. Then Dr. Balav will give 20-minute presentation about HLH. Then Dr. Udira will talk about MISC for another 20 minutes. So then we have 10 minutes for questions and answer. Again, Dr. Ali is from University of Texas Southwestern Children's Medical Center, Texas. And Dr. Balav is Associate Professor of Pediatric at UMass Medical School. And Dr. Udira is Associate Professor of Pediatric ICU at Wellington, Delaware, USA. And Dr. Michael Canary is Associate Professor of Clinical Pediatrics at Yale School of Medicine. So great moderator, great speakers. So housekeeping stuff, if you have any questions, please feel free to type it in the QA box. All the questions will be answered by the end of the session. All attendees should receive their certificates by next week. And if you want to read and to see the transcribed lecture on your screen, please try to activate or enable the show caption option. Again, whatever knowledge, whatever education we are giving you, are not learning, we are not teaching you the facts, but we are trying to try to initiate critical thinking and brainstorming to let your mind trained to think better and to have this clinical case discussion and the challenges in these complicated cases to help to diagnose and treat them better. With that, I'm going to let Professor Michael Kanari to introduce our first speaker, Dr. Ali Ali.
Thank you, Dr. Al-Husseini. I think many of you know Dr. Ali Ali. He's a brilliant, young, very dynamic critical care fellow at the University of Texas Southwestern at the Children's Medical Center there. And he's going to describe a case of apparent sepsis versus hyperinflammatory syndrome and work through a lot of the pitfalls in those diagnoses. Thank you.
Hello, everyone, and thank you for having me. I'm Ali, one of the board members here at the World Institute of Critical Care and Emergency Medicine pertaining to the PICU Fellowship. In addition, I'm a fellow of pediatric critical care medicine at the University of Texas Southwestern here at Dallas, Texas, in the US. Since the discussion today is predominantly going to revolve around HLH and MISC, the next few lectures will be heavily involved in how to diagnose them. This is just a case-based discussion of an atypical presentation that you need to be aware of, but doesn't go into depth or details of how to diagnose HLH, but just gives a different twist of how you look at HLH and MAS in patients. So you were in the PICU, you get here, you got called from the floor to see a patient. They tell you it's a 6-year-old female. She was previously healthy. No medical history other than she was complaining of growing pains in both of her knees for the past 3 to 6 weeks. She initially presented to the emergency room about a day and a half ago, and it was presenting with high-grade fevers up to like 40 degrees Celsius. For 8 days now, she's been having fevers, she has severe fatigue, and she has a rash that usually presents whenever she's having those fevers. Initially, she went to her pediatrician, and her pediatrician about day 4 of illness diagnosed her with a viral illness and gave her supportive therapies and went discharged and was never admitted. She came to the emergency room on day 8, and you're trying to review her vital signs. They're telling you the ED, her vital signs, her temperature, she was febrile, she was a bit tachycardic, her blood pressure was normal, she was not that tachypneic, and she was not requiring any oxygen requirement. But right now, her current vital signs just continues to be febrile, even higher grade. She's more tachycardic, she's hypotensive, she's tachypneic, and she's on oxygen. And your thought process at that point, your concern, is this a patient that had a viral infection, a vulvobacterial infection, and now she's going into uncompensated septic shock. So you brought her up to the PICU when you're trying to do your physical exam, looking for a patient who was ill-appearing, irritable. She has a rash because she's currently febrile. She has significant abdominal distension. You could feel the liver and the spleen enlarge about 3 to 4 centimeters. You could feel cervical and axillary lymphadenopathy in her. They seem tender and swollen and quite mobile. She is tachycardic, but you don't hear a murmur or a gallop. She has a prolonged capillary fill time, cold extremities, dry mucous membrane, a bit cracking in her mucous membrane as well, and kind of a red tongue. You paid attention in rheumatology class, you do a good musculoskeletal exam on her, and you see that both of her knees are swollen and tender. You see that she has tenderness on her sacroiliac joint radiating from her flanks. Kind of do a tender joint count and a swollen joint count on her, and you see that it's quite positive, actually sits in the 20s. And there's a picture of the rash that you see. In your mind, you're thinking, worst case scenario, there's a patient who's in septic shock, uncompensated, or with multi-organ dysfunction if you look at her labs further. Or is this a patient that has atypical presentation of Kawasaki disease? Is this a patient of MISC? And you look at her initial labs in the ED, and you see that they did a CBC where the WBCs were about 32, is not very elevated. It's actually on the lower side. She has slight anemia. It's a macrocytic normochromic anemia. She has thrombocytopenia. Her CRP is elevated. There's additional labs that you saw from the AD as well. Her procalcitonin was high. Her ESR was elevated. She had electrolyte derangement, or she was hypernatremic. She had elevated BUN and creatinine. So the initial thought that she had more of a moderate to severe dehydration with pre-renal AKI in the settings of viral illness, and that's what the ED was working with to admit her to the floor. So you wanted to have more suspicion, so you sent more inflammatory markers. You saw that her ESR dropped drastically. Her ferritin is skyrocketing. She has elevated in her triglycerides. Her fibrinogen is trending down. She has an element of transaminitis. Her AKI continues to worsen. Her coagulations is fine, so it tells you more that she's not in DIC. Her function of her liver remains intact, but there's an inflammation of her liver, and your repeat CBC shows persistent thrombocytopenia, persistent anemia with bicytopenia. So we'll take a pause. As we're thinking of HLH, it's important for you to look at this kind of a lab crash that you see with MES and HLH, where you look at initial elevation in their ESR, and then it drops drastically as your ferritin is rising. And it's paradoxical effect. You'd think it's the inflammation trending down, but it's more of a consumption. In HLH or MES, there's a liver dysfunction and there's consumption of fibrinogen. And without fibrinogen, the RBCs cannot aggregate, so your ESR basically crashes. And even though it might give you a false effect that you think the inflammation is less, it's actually more of a sign of consumption of hyperfibrinogenemia. Since that patient, you had physical findings on the patient. You did an ultrasound of their liver and their spleen. You see enlargement of their liver and spleen. You see some free fluid around them. An X-ray of her chest, you see increased pulmonary vascular markers, maybe like mild pleural effusions, bilateral. Tells you there's systemic inflammation going on. Even though the patient is irritable, she becomes more and more irritable, a bit more somnolent. She's able to protect her airway and non-invasive. She still maintains her oxygenation and ventilation. After multiple discussions between CT and MRI, you did the high imaging and you discovered also inflammation in her brain. So here you do have a thought. Now you're suspecting more of a MAS HLH picture in the back of your mind. You're looking back at different criterion for MIC, different criterions for Kawasaki disease, which we'll discuss in the lectures to come. But usually with HLH being suspected, you do a CBC, you do a liver panel, you look for your fibrinogen, your triglycerides, your coags. It's very important to understand that CXCL9 and soluble interleukin 2Rs also, if you have the resources available, these are very also pathognomonic for HLH and MAS. Now, it's important to also factor in multidisciplinary approach, as this is a patient that will need a CSF if stable bone marrow biopsy. Important to keep in mind is about 17 to 20% of patients proven to have genetic HLH disease have been observed to have incomplete or atypical presentation. So it's not a slam dunk diagnosis. And one approach to differentiate kind of HLH from lymphoma, but it's not the gold standard for your differentiation, is your ratio between your soluble interleukin 2R and your ferritin. It's also important to understand you have to differentiate between HLH with mass from familial HLH in some patients. It depends on the total interleukin AT ratio with CXCL9. But these are more focused on the management with your rheumatology and your hematology folks rather than your ICU management. But it's important to keep in mind the different types of HLH, whether it's genetics, whether it's familial, whether it's secondary, primary, or MES HLH, secondary to rheumatic diseases. So here, a patient, you don't want to start any therapies before you rule out any malignancies in these patients. So you did a bone marrow biopsy for this patient, and you see that there's this smoking gun approach, that you found those hemophagocytosis cells. Even though they are pathognomonic, their absence does not rule out disease, especially with MAS, because initially on it could be a patchiness, and you maybe just got the wrong patch of your bone marrow biopsy. So once you already have the diagnosis, you look at the patient, you know that she fulfills criteria for her fever, splenomegaly, bicytopenias, among other findings, and you want to see a criterion about 5 out of 8 of those for you to go. For this patient, fulfills about 5 criteria, which was the spleen, the liver, the bicytopenias, the fevers, the triglycerides, and also the fibrinogen and the ferritin. So now there's a diagnosis of MAS in patients with juvenile idiopathic arthritis, and it's basically predominantly ferritin, and this is based on ULR diagnostic criteria for rheumatological diseases. So you look at ferritin plus 2 other following findings is predominantly our platelets, liver enzymes, triglycerides, and fibrinogen. So there's a matrix of differential diagnosis for these patients, but eventually this patient is diagnosed with MAS HLH subtype in the settings of systemic juvenile idiopathic arthritis. It's important because there's that vague history that sounds like rheumatological that needs to be hammered further down, and then you discover the patient basically had a crash evolve, which is called a MAS switch, when the patient is having rheumatological disease, had an acute flare, have a switch to MAS from there, and it's very life-threatening disease. We will discuss further how to navigate therapies for MAS or for AHLH or MISC. You have to understand steroids and anakinra are very important to suppress the hyperinflammation state. Here the patient was benefited from cyclosporin since it was having an underlying rheumatological disease, but we have to also think for rituximab, IVIG, Plex in patients with EBV. We're thinking more of antithymocyte cycloglobulin, cyclosporin A, rituximab, rioxulinib as well. These are all immunomodulators that varies based on the subtype of HLH that you're treating, but most commonly you use steroids and anakinra predominantly. Sometimes they might benefit from plexing and IVIG, depends on the subtype. And of course, this goes hands in hand with your hematological colleagues, oncology colleagues, and rheumatology as well. Thank you for giving me the time to do this case-based discussion. And I want to just basically make you aware of MAS HLH subtype in patients with rheumatic disease. And I hope the next lectures answer further more questions about HLH pathophysiology, diagnosis, and MISC. I'm more happy to discuss and answer any further question that is needed as well. Thank you guys very much.
Great presentation. Thank you so much, Dr. Ali, for this very nice case-based discussion. And I think this is helping us to open the discussion and to open our mind to the next speaker and to pave the way to Dr. Pallav Bhattari, the Associate Professor of Pediatric at UMass Chin Medical School, who is going to talk about HLH. Will give a 20-minute detailed presentation, management, diagnostics, and hopefully by the end of this talk, we'll have a better understanding of the HLA diagnosis and management.
Hello, everyone. My name is Pallav Bhattari. I'm one of the pediatric critical care physician at the University of Massachusetts Chan Medical School, Children's Medical Center here in Worcester, Massachusetts. And today I'll be talking to you about hemophagocytic lymphohistiocytosis, or HLH for short. I don't have anything to disclose. So the objectives of this talk and this presentation will be to define HLH. We will talk about the pathophysiology of HLH, review the diagnostic criteria for HLH, outline the treatment options, and in the end, summarize key points. So this was the most concise definition of HLH I could find, and it states that HLH is a severe and life-threatening syndrome which is characterized by overwhelming inflammation that often leads to multi-organ failure and death if not treated promptly and appropriately. So there's two things that's happening. One is, it's a severe life-threatening syndrome, and there is overwhelming inflammation associated with this disease. Just a one-liner on macrophage activation syndrome. You will be having a presentation later on regarding this. So I just wanted to give you a brief one-liner. So when HLH is associated with pre-existing rheumatological disease, that is macrophage activation syndrome. So HLH can be seen in inherited defects as well as acquired conditions. And like we mentioned in the definition, the hallmark is hyperinflammation resulting from elevated circulating cytokines. And it is an emergency. So you need to be vigilant about it. When you suspect it, initiate prompt investigations, have a multidisciplinary approach to it, and initiate prompt treatment. HLH goes all the way back to 1939 when Scott and Rob Smith, they described a disorder in adults, a fatal disorder which was characterized by fever, wasting, cytopenias, hepatosplenomegaly, and active phagocytosis. 1952 was when familial HLH was first described. 1979 was when the virus-associated HLH was first reported. And 1999 was when the causative gene associated with familial HLH was reported. And this gene is the PRF1 gene, which we will talk about in the pathophysiology of primary HLH. So there are different types of HLH. Primary and secondary are the big groups. Within the primary, there's HLH associated with lymphocyte cytotoxic defects, HLH associated with abnormalities of inflammation activation, associated with other Mendelian disorders, and of unknown origin. Out of all this, just one point for you all is Chidiac-Higashi syndrome, which is associated with the lymphocyte cytotoxic defect. Somehow they like to ask this in PEDS critical care board, so I would definitely read about this. I've not seen it personally, Chidiac-Higashi syndrome, but it's a favorite for the boards. Now, continuing the HLH types, the secondary HLH types, which we usually see commonly, these are the ones associated with your viruses. Epstein-Barr virus is the most common, associated with bacteria, parasite, fungus, and malignancies, right? So there are different kinds of malignancies that can be associated with HLH. HLH, those are triggered by cancer, like I said, occurring during chemotherapy, and associated with other autoimmune conditions, such as your macrophage activation syndrome, which we will talk about later. Continuing with the secondary HLH, there's this HLH associated with transplant, HLH associated with immune activation, iatrogenic immune suppression, and other non-Mendelian conditions, and HLH associated with uncertain origins. Now, the clinical features of HLH, whether it be primary or secondary, are quite similar. And it's often hard to distinguish between the primary and secondary forms of HLH. A note, primary is more common in infants, and secondary is common in children and adults. A typical presentation of HLH would be like a sepsis-like condition, right? So, you know, they may present in sepsis, septic shock, they have cytopenias, they might be coagulopathic, they might have hepatosplenomegaly associated with a febrile illness. Now, when patients are admitted from the emergency room in the pediatric ward or in the pediatric ICU, when the fever is ongoing for more than 5 days, I think it's important for us to think about HLH at that time. Of course, there can be a lot of differentials, and few of the differentials we will discuss later in our presentation, but just something to be vigilant about when someone has fever for more than 5 days, 5 or more than 5 days. They can be associated with thrombocytopenia, anemia, part of your sepsis, viral suppression, or bacterial infection, or any other cause that's causing sepsis. And then they can have hemophagocytosis when we start to do the lab investigations. Of note, hemophagocytosis is not always present, not in the early phase of the disease, And there can be other bone marrow findings as well, which can be histiocyte hyperplasia and hypercellularity. When we start to check labs, there can be elevated transaminases, elevated aminotransferases, and elevated ferritin level. And I would say elevated ferritin level is usually the hallmark of HLH. Now, the ferritin level is not high. It's normal. Then it's a little bit hard to argue, if this patient has HLH. And it'll be interesting to see what the discussion is, regarding this when we discuss this further. There can be hyperbilirubinemia. There can be elevated gamma glutamyl transferases, elevated LDH, and patients might have neurological alterations, meaning, they might present with seizures, they might present with decreased consciousness, and signs of meningismus as well. They can have ataxia, and when the platelets are low, they can have petechiae, they can have purpura, rash may be the presenting feature as well, and lymph node enlargement, right? So you see, all these signs, petechiae, purpura, rash, lymph node enlargement, fever, labs showing cytopenias, elevated transaminases, patient with altered level of consciousness, all this can mimic sepsis-like condition. So if the patient, whether the patient is in the ICU or the general pediatric ward, if it, he or she is not getting better, and if it does not make sense, you've started the appropriate treatment for sepsis, for infections, if it's not making sense, why the patient is not getting better. It's been about 5-6 days now. The patient is still febrile. We are seeing these lab abnormalities. It makes sense to think about HLH. This is a slide regarding the pathophysiology of HLH. On the left, you have the pathophysiology related to primary HLH. And on the right, this is the pathophysiology related to secondary HLH. Now, there are 3 cell types that are involved in HLH. One is macrophages, the second is natural killer cells, and the third is cytotoxic lymphocytes. In HLH, the natural killer cells and/or cytotoxic lymphocytes fail to eliminate the activated macrophages, right? So normally the activated macrophages are eliminated by natural killer cells and the cytotoxic lymphocytes through porphyrin-dependent cytotoxicity. And this is encoded by the PFR1 gene that we discussed about briefly in the history, which was discovered in 1999. What happens is that porphyrin creates a pore in the macrophages, in the membrane, and delivers the cytotoxic granules into the macrophages. And this causes apoptosis, programmed cell death, which you all know about. In familial HLH, primary HLH, this process is deficient, right? Consequently, what happens is that the loss of porphyrin expression significantly blunts the cytotoxic function of lymphocytes. And then there's inability to deplete the antigen-presenting cells. Activated lymphocytes secrete high levels of gamma interferon, which activates macrophages, and it's a cascade. And there's an exaggerated, response. There's cytokine storm, and that is what activates things. When there's acquired defect, and this has been highlighted here in diagram on your right, the cytotoxic activity of NK cells and cytotoxic T lymphocytes leads to defective clearance of cells. This drives the stimulation of other immune effector cells and uncontrolled release of cytokines, which activate macrophages. Activated macrophage then secrete additional cytokines like TNF-alpha, IL-6, IL-1, which creates a cytokine storm. So 3 cells that are involved. One is your macrophages, one is natural killer cells, and the other one is cytotoxic lymphocytes. There is association of the PFR1 gene in the primary, and then in the secondary, because of triggers, whether it's infection or malignancy or, all the things that we discussed. There's a cytokine storm with secretion of TNF alpha, IL-6, IL-1, and that causes the symptoms of HLH. Now you have a patient that you suspect is having HLH. Now, how do we diagnose it, right? So in 2004, the diagnostic criteria that came out required 5 out of 8 criteria to be met. And these 8 criteria was fever, which is present in 95% of the cases, splenomegaly, cytopenias, fasting hypertriglyceridemia, and or hypofibrinogenemia, elevated ferritin, CD25 count, hemophagocytosis in bone marrow, CSF, or lymph nodes, and decreased or absent NK cell activity. So you had to have 5 out of 8 criteria to diagnose someone with HLH. In 2024, they eliminated the NK cell activity criteria because this assay is not widely available. So now 5 out of 7 criteria is needed to diagnose HLH, and they removed the decreased or absent NK cell activity. Of note, like we mentioned in our previous slide, hemophagocytosis in bone marrow, CSF, lymph nodes, especially in the bone marrow, is not needed. And there can be other features, especially if you're diagnosing someone in the early stages, this might not be evident. So bone marrow might show histiocyte hyperplasia or hypercellularity. So once you've diagnosed someone with HLH, now we need to treat them, right? So the important factors that need to be considered and the goals of treatment would be to find and treat a possible triggering factor that is causing HLH, whether that's infectious causes, whether that's malignancy, whether that's an autoimmune process. So that is important. And when you find a possible triggering factor, when you're dealing with patients with secondary HLH, you might not even need to transplant these patients. So that is one, is to find and treat possible triggering factors. And the other important thing to consider is the hyperinflammation should be calmed to prevent organ damage, right? So when there's macrophage activation, macrophage goes in your bone marrow, in the liver, in your spleen, and your lymph nodes, and then that causes a lot of chaos. So hyperinflammation must be promptly calmed, and then you need to find and treat the triggering factors. When patients present with HLH and when there's an association with a genetic cause or a lack of response to the initial therapy, when there's CNS involvement, when there's malignancy, I think it becomes imperative for us to think about transplant in these patients. And this should be considered early, in my opinion, before it's late in the treatment process. Now, what I like to say is, different institutes have different protocols for the management of HLH, but the most common ones, and I believe people will agree, is to use etoposide and dexamethasone. And of course, stem cell transplant is always there, and we need to think about it. Some places use cyclosporin A, some places don't. I think the drawback of cyclosporin A, of course, it has its toxic effects, but the one that comes to mind is PRES, posterior reversible encephalopathy syndrome. So some centers shy away from using cyclosporin A. If there's CNS involvement, intrathecal methotrexate and hydrocortisone is used, but most places would start with etoposide and dexamethasone. In addition to etoposide and dexamethasone, other treatment options have also been listed in the literature, and different institutes, like I said, use some different treatment modalities. There's human monoclonal antibody, especially against INF gamma, which is imapalumab, which is used by some centers. You have inhibitors of interleukin-1, like anakinra, inhibitors of IL-6, like tocilizumab. There's Janus kinase inhibitors, like ruxolitinib, and intravenous immunoglobulin has also been used in places and with HLH. When we do start them on treatment with etoposide, dexamethasone, anakinra, or imapalumab, to name a few, and others like you see there in the slide, it's important to monitor response. Commonly used, lab values or lab parameters are to check ferritin levels and to check CXCL9, which is chemokine ligand 9, which is a biomarker for gamma interferon-driven hyperinflammation. So centers use this, and this is also kind of like a bridge to transplant, right? So you have someone who comes in with HLH, you've diagnosed them as having HLH, you start them on treatment, you see how they are responding. If they're not responding with the treatment that was just mentioned, then of course there's a discussion to initiate or talk about stem cell transplant. So these are the biomarkers that are used in addition to monitoring your CBC, your checking, monitoring the transaminases and other parameters. Supportive treatment is always important. We make sure they're not anemic, they're not thrombocytopenic, they're not bleeding, they don't go into DIC. Now, know that these patients are very sick, right? So in addition to treatment with etoposide and dexamethasone, which is the classical treatment, including when you add other agents, like we discussed, you have to be monitoring them for these things, whether they go into DIC, whether it's, other associated infection. You start them on steroids, the blood pressure can go up. And then, we think about PRESS in those patients. So there's tight control of blood pressure, monitoring of their hemodynamics. So they're usually cared for in the pediatric ICU, where you can monitor the hemodynamics and check frequent labs and provide supportive treatment. When we have or when we suspect patients with HUS, there are a few differentials that you need to think about, and the common ones I've highlighted here. Of course, if patient is septic and or in septic shock, not getting better with your treatment modalities, and like we said, these patients will be cytopenic, they'll be coagulopathic, they can go into DIC, there'll probably be an infectious source for sepsis, and if they're not getting better, you think about HLH. Patients have liver disease and or liver failure because of any other cause. They're coagulopathic, they have pancytopenia, bicytopenia. You think about HLH. When they have multi-organ dysfunction, not getting better, think about HLH. In our pediatric population, Kawasaki and or incomplete Kawasaki becomes important because these patients present with fever more than 5 days. In a typical Kawasaki patient, of course, the rash, the conjunctivitis, the lymph node enlargement, the desquamation of the skin, the strawberry tongue, which you all know about, might be classic, right? So hence the classic complete Kawasaki disease. But in incomplete Kawasaki disease, they might just have lymph node enlargement. They might just be having fever for about 5 days or more. When you check your labs, the transaminases might be high, the albumin might be low, they might have thrombocytosis, anemia might be present, transaminases, like I said, might be high. So it falls in that gray zone, whether it's HUS, whether it's HLH or not. So these patients, you need to think about, when you're dealing with kids with incomplete Kawasaki and other conditions like I've highlighted there, to think about HLH. Kids with thrombotic thrombocytopenic purpura, they have purpura, They have their CNS manifestations. Kids with or patients with hemolytic uremic syndrome, right? Microangiopathic hemolytic anemia, thrombocytopenia, renal insufficiency. So your organ system is involved. The creatinine or the BUN might be high. There might be hemolytic anemia. There's thrombocytopenia. These kids are on the sicker side, not getting better with your treatment. Think about HLH. So I think you need to be very vigilant about it. You will probably see a few cases of HLH in your training, and once you complete your training and wherever you're practicing, you will come across it. So just to be vigilant about it, I think that's the take-home message from this slide. To summarize, it's a life-threatening condition, but it's definitely treatable. It is still underdiagnosed, so reassessment of these patients at multiple points is necessary. Why is my patient not getting better? If this patient does this patient have organomegaly? What's going on with the labs? Does this patient has any other features that I'm missing? And it should be considered definitely in patients with sepsis-like critical illness that does not respond to your adequate empirical treatment. It is very important. That's why I've highlighted that there. And once you suspect, once you initiate labs, there needs to be a multidisciplinary approach. So the primary team, whether it's ICU or the floor, they're involved anyways. Hem-onc is involved early on. Infectious disease is involved. Pharmacy is involved. So it's a multidisciplinary approach for these patients. And as we continue to understand these patients, the treatment, it will continue to evolve. The diagnostic criteria has already changed from 2024 to 2004 to 2024, and the treatment modalities is different, right? Whether we use cyclosporin A or to refrain from it, and few other things like we discussed will continue to evolve definitely. These are my references for this presentation. And I'd like to thank for giving me this opportunity to present about HLH. That is my email there. Please feel free to reach out with any comments or questions.
Great presentation. Now, Dr. Michael Canary is going to introduce our second speaker, Dr. Idira. Then we'll go to the QA session right after that.
Great. Yeah, I do see some interesting questions that have appeared, so hopefully we'll address those later. I'd like to introduce Dr. Idira Nwankwo, a very good friend and an associate professor of pediatrics at the Jefferson School of Medicine in Philadelphia. He's also a senior PICU doctor at Nemours Children's Hospital in Wilmington, Delaware, and a very dynamic educator. Thank you.
Hello, welcome to today's webinar. My name is Idira Nwankwo. I'm a pediatric intensivist at the Nemours Children's Hospital, Wilmington, Delaware, and I'm also a clinical associate professor of pediatrics at the Sidney Kimmel Medical College at Jefferson University, Philadelphia, Pennsylvania, all in the United States. We're going to be discussing multi-system inflammatory syndrome in children, otherwise called MISI. The outline of today's discussion, we're going to start with history and definitions of MISI, and then we'll smoothly go into epidemiology, and we'll look at a brief pathogenesis, and then we'll delve more into the clinical manifestations. But very importantly, we're going to talk about the management, and we'll finish up with looking into prevention and prognosis. Now, how do you define multi-system inflammatory syndrome in children, MISI? Actually, there's no specific definition for this condition. However, there are 4 things that has to be in place for one to diagnose a child with MISI. One is that It is a dysregulated autoimmune-mediated illness. 2, in genetically susceptible patients, and there has to be a history of COVID infection or exposure to someone who has COVID. And there has to be an interval of 2 to 4 weeks after that exposure to COVID-19. You all know that in 2019, there was a pandemic, the COVID pandemic. Then in April of 2020, we started seeing cases, reported cases of very severe inflammatory syndrome that was following exposure or infection with COVID-19. These cases were reported almost worldwide, mainly in Italy and New York. And the features of these conditions were similar to what happens in Kawasaki disease. Now, for case definition of MIS-C, the Center for Disease Control and the World Health Organizations have a very similar criteria for defining MIS-C, but a little bit slightly different. For a case definition of MIS-C, there has to be fever. For CDC, there has to be fever that has lasted equal or greater than 24 hours. For WHO, that fever would have lasted more than or equal to 3 days. There should also be elevated inflammatory markers like the ESR, the CRP, and there must be multi-system involvement involving more than 2 systems: cardiac, gastrointestinal, mucocutaneous. And there should also be evidence of recent COVID infection or exposure to someone who has COVID. For CDC case definition, there has to be a requirement of hospitalization for these index cases. For WHO definition, there does not need to be hospitalization for MIS-C to be defined. But finally, there should not be any other plausible cause of this severe inflammation and no infection causing this severe inflammation. So these are the systems that will be required for case definition of MIS-C. So table 1 actually is quite interesting. It's an outlay of the criteria for case definition of MIS-C according to the US Center for Disease Control and the World Health Organization. Like I said earlier, for the most part, they are similar. Age less than 20 years for CDC, less than 19 years for WHO, almost similar. There are 2 major differences, and that is for fever and the requirement of hospitalization. For fever, for CDC case definition, that fever would have lasted for greater than or equal to 24 hours. But for WHO, the fever must have lasted for greater than 3 days. The CDC requires that for case definition of MIS-C, that there should have been a hospitalization of the case. For WHO, you don't need any requirement for hospitalization. However, what I really want to point out here are the laboratory evidence of inflammation. Depending on where you practice, these are some of the labs that you're looking at. You're looking at elevated ESR, elevated CRP, elevated fibrinogen, procalcitonin, D-dimers, ferritin, LDH, interleukin-6, neutrophils, reduced lymphocytes, and low albumin, almost similar to the WHO criteria for case definition as well. Now, let's look at the epidemiology of MIS-C. The incidence of MIS-C among children who have been infected with COVID is actually relatively small. It's approximately about 0.4 to 5.5 cases per 100,000 cases of COVID. It is actually higher among Blacks, Hispanics, and Pacific Islanders. It is almost equal among Asian kids and white kids. You remember, in Kawasaki, is exactly opposite. The Asian kids are much more than the white kids in Kawasaki. With regards to age, the median age of MIS-C is between 6 to 11 years of age. For Kawasaki, is usually less than 5 years of age. Male predominance is also seen. The ratio is about 3 to 2. And this is also a disease of lower socioeconomic status. It is interesting to note that some variants, the Delta and the Omicron variants, usually show low incidence and milder illness. The pathogenesis of MIS is actually very interesting. I want us to know that COVID-19 infection itself is associated with an autoimmune phenomenon. Then MIS, just like Kawasaki, is considered to be a dysregulated or over-exuberant immune response to SARS-CoV-2. And this causes massive cytokine storm. This does not happen to every child that has COVID. It happens in select children who are genetically susceptible. And this leads to endothelial damage, generalized endothelial damage. It's almost consistent with features of what you see in vasculitis. In gene analysis, a lot of gene polymorphisms are predisposed to the development of MIS. And all these mutations are all linked to the same thing, final common pathway of exaggerated inflammatory response. Now, the receptors of SARS-CoV-2 is the S-angiotensin converting enzyme receptor and is found in all these organs, the heart, the kidney, the lungs, the intestine, and the endothelial cells. That is why most of the features, the multi-system involvement that you see in MIS involves more than 2 of these organs. So the symptoms of MIS will usually occur after about 2 to 6 weeks following COVID-19 infection or exposure to someone who has COVID. The problem is that most of the symptoms of the COVID-19 are usually very mild or asymptomatic. So you may not have known that you had COVID infection before the MIS symptoms occur. However, the organs that are usually affected in MIS are usually the GI, the cardiovascular, the hematologic, and the mucocutaneous. The respiratory, CNS, musculoskeletal, and renal are usually less frequently affected. So the symptoms of MIS starts with fever, almost 100% of the cases. And this fever duration is between 1 to 7 days. So this takes care of the definition of MIS with regards to WHO definition and the CDC definition. The organ system that is most commonly affected in MIS is GI, is gastrointestinal. We have over 50% of cases of MIS having vomiting, diarrhea, abdominal pain. Sometimes you might have features of appendicitis, pancreatitis, intussusception. And on some imagings, you might see some enlarged mesenteric nodes, and you might see some intestinal wall thickening, and sometimes you might also see ascites, depending on the mode of imaging that you got. Then the cardiovascular system is profoundly affected with hypotension and shock, again, greater than 50% of the cases. And this is usually what brings them to the hospital. And the hypotension that we have from MIS is a combination of myocardial dysfunction and some preload reduction. I call it relative preload reduction because what happens is that the absolute intravascular volume is still the same, but because of the massive inflammation and the peripheral vasodilatations, the preload relatively decreases. The mucocutaneous system involvement in MIS almost mimics what you see in Kawasaki disease, and this is where it gets a little bit confusing. You would have conjunctival injection, you have this in Kawasaki, you have red or fissures lips, strawberry tongue, cervical lymphadenopathy, skin rash, palmar and plantar edema, erythema, and disformation of the digits. However, in MIS, some of the skin lesions are petechial and purpuric. This is not very common in Kawasaki disease. For the labs, you're going to have elevated inflammatory markers like we had mentioned earlier, the ESR, the CRP, the procalcitonin. The ferritins are also high. The fibrinogens are also high. These are features of diffuse inflammation. And then in cases that you have myocardial injury and hypotension, you will see elevated troponin and pro-BNP. The EKGs might show some left ventricular dysfunction and some arrhythmias. Now, kids who have mucocutaneous lesions, significant mucocutaneous lesions in MIS that looks like Kawasaki would also, among them, up to 10 to 48% would also have coronary artery dilatation. Other laboratory findings would include the CBC that will show features of anemia and lymphopenia. The D-dimers would also be elevated. Liver function tests usually would be abnormal, and you would also have hypoalbuminemia, and you have features of AKI and sterile pyuria when you look at the urine. So what about infectious disease workup? Only about 21 to 52% of patients who have MIS-C will test positive for SARS-CoV-2 at the point you make the diagnosis of MIS-C. I want you to remember that MIS-C is a post-infectious complication of COVID-19. So the absence of positivity for SARS-CoV-2 does not rule out the diagnosis of MIS-C. So table 2 just basically shows the clinical manifestations of MIS-C in children. The emphasis here really is what we've said before, that fever occurs in almost 100% of the cases, and the gastrointestinal system is the most commonly affected, about 60 to 100% of the incidence. Now that we know how to identify children with MIS-C, let's now move into one of the most important parts of this discussion, which is management of MIS-C. A significant proportion of patients, about 31 to 85%, require intensive care. They require intensive care for fluid resuscitation, inotropic support, mechanical ventilation, and in very severe cases, extracorporeal membrane oxygenation, ECMO. Also, these kids usually will need antibiotics. In future slides, we'll be talking about the fluid resuscitation and inotropic support. Hypotension or shock is a very significant feature of cardiovascular dysfunction in MIS-C. And the hypotension or shock is usually from a combination of myocardial dysfunction, decreased vascular tone, and relative volume depletion. So for myocardial dysfunction, we usually will start with inotropes like epinephrine and dobutamine. But because we know also that they have decreased vascular tone, we usually would add norepinephrine as a second line. Now, we can start with fluid resuscitation, but these kids are usually fluid resistant. So as you give them fluid, please remember that you don't want to fluid overload them. You give them a small amount of fluid, then you start them on inotropes. In addition to the management of cardiovascular dysfunction in children with MIS-C, you would also have to remember that you would add immunomodulators. There are 3 scenarios where you add immunomodulators. One is as a routine management, or in cases with severe cardiac dysfunction, or those who are refractory to initial management. For routine management, you're starting them on IVIG, 2 grams per kg, plus low-dose steroid, 1 to 2 milligrams per kg per day. This is basically to suppress the hyperinflammatory state. In children who have significant cardiac dysfunction, you would have to spread the IVIG over 2 days. So instead of giving them a one-time dose of 2 grams per kg, you will start them on 1 gram per kg daily for 2 days. Now, those who are refractory to these initial treatments, you will have to also start them on high-dose methylprednisolone, that is 10 milligrams to 30 milligrams per kg per day, or high-dose anakinra, that's 5 milligrams to 10 milligrams per kg daily, or infliximab, 5 to 10 milligrams per kg for just 1 dose. Now, you can now taper these immunomodulators over 2 to 3 weeks or even longer. So in addition to the immunomodulators, we also need to start heme prophylaxis or actual anticoagulation on these kids with MIS-C. So we would start low-dose aspirin, 3 to 5 milligrams per kg per day, the same dose that we do for Kawasaki. And we will continue the aspirin for at least 4 weeks, or until inflammatory markers normalize, or until the coronary arteries are shown to be normal. However, we will do actual anticoagulation for patients with large coronary artery aneurysm, or those that have moderate to severe left ventricular dysfunction, or those with documented thrombosis. Now, we're almost coming to the close or the end of this discussion, but it would be nice to look at the prognosis and prevention. The prognosis for MIS-C is generally very good. Most of the cases will show resolution of symptoms within 1 to 4 weeks. However, long-term follow-up is recommended because some that have coronary abnormalities may continue to progress even after discharge. And we have also found out that at the 6-month follow-up, Some of the kids might still be struggling with emotional difficulties, exercise intolerance, and some of them with impaired neurological function. The mortality is between 1 to 3, and this is just a little bit slightly higher than what we have in Kawasaki disease. Finally, prevention. The COVID vaccines work. They are highly effective against MIS-C. The protective effectiveness is reported at 91 to 94%. And it has similar protection against moderate to severe COVID-19 and is much, much, much higher against mild COVID-19. So this vaccine works against MIS-C. Now we're going to conclude this discussion by looking at this table that compares MIS-C and Kawasaki. These are two disease conditions that have features that look so much alike. However, there are a few differences. With regards to age, MIS-C is commoner in children less or equal to 20 years of age with peak between 6 and 11 years, while Kawasaki is commoner among children who are less than 5 years of age. Now, if you look at organ involvement, cardiovascular dysfunction in terms of shock and gastrointestinal symptoms are much, much commoner in MIS-C than are in Kawasaki. If you look at some of the lab results, lymphopenia and thrombocytopenia are commoner in MIS-C and almost very rare in Kawasaki. Inflammatory markers are highly increased in both of them, 100%. However, other labs like troponin, BMP, ferritin, D-dimers are markedly elevated in MIS-C, but these are quite rare in Kawasaki. Very good. So I'm going to stop here, and I hope this was useful to you, and I welcome your questions and comments. Thank you so much for your time and listening. These are some of my references.
Okay, thank you for all speakers for this is a very important subject for us as a pediatric intensivist. And we'll go now to the question part, which is, I know the time is limited. Now we exceed 1 hour. I will start with the first question, which is choose the first one. There is some questions there. Okay. The first one, what is the hallmark about HLH feature? Can HLH present without fever? Professor Mark?
The question is for you, Professor Canary, and I think the straightforward answer, it's extremely rare for HLH to present without fever, but I think it can happen in immunocompromised patient, patient with cancer, or in neonates also can happen. But I think Dr. Canary would be able to answer better.
Excuse me, yeah, I agree entirely. Sorry, I have some colleagues tracing by. I would say it's more common not to have fever in congenital or more atypical HLH, but I think that for fulminant or secondary HLH, fever is almost omnipresent.
Agree.
Okay, very good, yes. Second question, it's about the C-reactive protein. Absence of the C-reactive protein elevation definitely rule out, is it definitely rule out HLH, especially in the resource constrained setting where the advanced diagnostic mark is not available? What are the most reliable clinical surrogate and biochemical trend to differentiate infection associated hyperferritin to the secondary HLH?
Yeah, so I would say this. I would say that most of the data we have on this comes from high-income countries, and that is both recognized triggers for secondary HLH, but also a lot of the markers that we use. So it may be impractical to actually to follow those markers in many low middle income countries. I will say this though, if you look at the diagnostic criteria, You can probably make a definitive diagnosis of HLH without a lot of the more expensive and less available biomarkers. For example, fevers, splenomegaly, bicytopenia, fibrinogenemia, etc., and then a fibrinogen level. And you can cinch up a diagnosis, I think, based on that. So while it is true that much of what we read and see depends on a much more elaborate workout, I think that the essence and the essential diagnosis can be made with those categories. And so I would say a CRP may or may not help, but I think it's such a non-specific marker of inflammation that it's nice if it's positive, but I don't know that it would sway me one way or the other in isolation.
Okay, thank you, Dr. Karani. The other question about the hyperferritinemia, sepsis management, when to decide to give pulse steroid, is it if it is the ferritin level around 500, is it enough?
Yeah, thank you, Doctor. And I'd like to, our friend Dr. Juma asked a question that's sort of vaguely related to that. And I would say that, first of all, we commonly see elevated ferritins in a variety of critically ill patients, particularly those with infection. I would say to that, I would say yes, to have an elevated ferritin is really important for making the diagnosis. But I would say that you can use the other criteria, I think, to support your diagnosis. So I don't think any of us would diagnose HLH based on a ferritin that's high because we see it so commonly. So I think that there are enough other clinical or lab values that could support the diagnosis that you wouldn't need to depend solely on that. And I think if you don't mind, I know time's running out here. I saw Dr. Juma had a great question. And that is that, can I read it if you don't mind?
Yeah, no problem. Go ahead. Yeah.
Okay, so when considering initiating immunomodulatory or other definitive therapies, how long should we wait given the high risk of triggering or exacerbating an underlying infectious process? Is there a recommended waiting period? And Dr. Juma, that's a great question, but I think that the thing about all these critically ill patients when they present, there's a lot of signal, right? All different
Yes.
signals. And I think the point is, what are the strongest signals? And then, of course, what is the clinical context? So if you have a patient who's deteriorating in front of what you think are reasonable therapies, broad spectrum approach to managing what you perceive might be a patient in septic shock, I think if they haven't responded initially, and I would say, we conventionally use 48 hours as this magic period, but I would say at the end of that period, if your patient continues to be febrile and unstable, I think it's time for you and for all of us to think about other treatments because in fulminant HLH, the trick is we have immunodysregulation. So we may not get a benefit from a counter-regulatory push, and in that dysregulation, sort of time is money because the greater the inflammation, the greater the damage. So that's a great question. We all sort of live in that gray area. And I think at a certain point, I often, when I was thinking about this talk, was making Venn diagrams, right? It isn't that what we do in our minds? We make Venn diagrams to help lead us to what we think is the most reasonable diagnosis under the current conditions. Thank you.
Thank you very much. I think because of the time, this will be the last question. Dr. Professor Karani, about the infection and HLH, does parasitic infection or streptococcus infection have any role in HLH through secondary immune activation, especially in the endemic area, if there is endemic area?
That's another great question. As I said before, so much of what we know and what's described about HLH comes from high-income countries. I think so when we talk about EBV, etc., this is from this population. I think there's no question that there may be parasitic involvement. We see evidence of leishmaniasis. There may be that malaria may be a trigger, dengue, etc. So as well as more commonly known bacterial infections. So absolutely, and I think as we get more data on this from low-middle income countries, from different regions of the world, I think the epidemiology of this and the triggers that are recognized will change dramatically. Thank you very much. I must step away, but thank you for a great session.
No problem, Doctor. I will leave for you to close marker about this nice webinar. The floor for you, Professor Karani, to close this webinar.
Okay, great. Well, thank you so much. I think all of our speakers did a great job of focusing on the salient features of the particular pathology they were describing. I think that Dr. Ali as well was dealing in that area of where we all spend most of our time in that diagnostic ambiguity area. And I think that at the end of the day, sometimes you just have to make columns of things, which makes the most sense under this condition. And you treat based on that data, you treat your patient aggressively. And thank you very much for the comments, and we'll see you next time.
Thank you so much, Professor
Thank you.
Kanari and Dr. Turki Al-Atibi for this very nice moderation. Please mark your calendar for our next webinar, June 30. We'll talk about the Surviving Sepsis campaign in pediatric. And all of attendees should receive certificate of attendance by next week. And by tomorrow, we should all also receive our YouTube recording of this webinar. So stay tuned, and I wish a happy rest of the day, the evening, and the night for all of you.
Thank you very much, Professor Amran, Professor Karani. Thank you.
Bye.
Bye. See you.